Good morning, everyone. Presenting on the behalf of Medicine for Great Imitator. Mr. X, 24-year-old gentleman, male from Jharkhand, presented with decreased vision in the right eye since last 15 days. It was acute onset, painless loss of vision, not associated with any redness of eye or any lacrimation. And there was associated nausea and vomiting for the last 3 days, which contains vomiting contains food particles, no blood stain, no bile stain, and it happens immediately after taking food. And there was occasional headache for the last 1 month, 2 to 3 episodes, bilateral, frontal. Release after sleep. Each episode lasts for at least 6 hours, but there was no history of any projectile vomiting, no history of fever, cough, breathlessness, loose stools. There is no history of trauma or decreased vision in the left side. So before going to the further history, I just put a different. What are the differentials for the acute onset of painless loss of visions? So we are running out of time. So so the differential considers the acute onset of painless loss of vision are retinal detachment, central retinal artery occlusion, central retinal vein occlusion, ischemic optic neuropathy, and acute onset of CV. So before going further with the examinations for this patient, there is some important background history which is relevant for this patient. So this patient actually came to us in 2022 August for the evaluation of fever, weight loss, and abdominal pain, which was lasted for 6 months at that time. So during the evaluation, he was found to have a LFT pattern with this of infiltrative etiology, that is increased alkaline phosphatase were there with normal protein, no SGOT, and SGBT elevation. And we run a PO evaluation. DBOs was negative. Bone marrow cultures all came negative. Showed no significant abnormality. Expert also came negative. HRCT chest was done, which did not show any significant abnormality. CT abdomen contrast showed significant lymphadenopathy with mild hepatosplenomegaly. Echocardiography was done, which did not show any features of infective endocarditis. Ultrasound for the lymph nodes and liver. So ultrasound guided liver biopsy was done, which showed granulomatous inflammation. And USG guided periportal lymph node biopsy was also done, which showed again showed granulomatous inflammation, suggestive of a probable tuberculosis. Renal biopsy was also done in view of elevated creat. After patient got admitted, his creat also started to increase. So and urine routine was normal at that time. So after consulting with nephrologist, we worked with the renal biopsy, and it showed a necrotizing granulomatous interstitial nephritis. Though there was no microbiological evidence of any tuberculosis. So patient was, and there was a multi-organ involvement, including liver, kidney, and lymph nodes. So he was empirically started on ATT with the tapering dose of steroid. And after starting on ATT and steroid, he became symptomatically better, and he got discharged. He was well for another 3 to 4 months. During this period also, though there was any worsening of condition, but there was no weight gain noted. And on April, he came to us with complaints of increased tiredness and decreased urine. Actually, he came to nephrology department, and they found out that his creatinine was elevated. Creatinine was 3.5. So nephrology admitted this patient, and he was found to have a hypercalcemia at that time. So he was conservatively managed with hydration, and after hydration, his creatinine also improved. And during this time, he complaints of redness in the left eye, but without that there was any vision loss. So they sent for an opthal consult, and the opthal document that there's a disc edema which was more in left compared to right, and he was asked to follow up in neurology department for further management, but he lost to follow up, and he currently came to us with his presenting complaints. And the steroid dose was getting tapered, and currently on the time of presentation, he was taking only 2.5 mg of prednisolone, and his symptoms worsened during the tapering of steroids. So coming to the examination, and otherwise comorbidity, he doesn't have any other comorbidities, so there is no history of any substance abuse also. And on examination, on arrival, his vitals were stable, and there was no pallor, icterus, clubbing, cyanosis, or lymphedema. There was no erythema nodosa, no lupus pernio, and mild apparent proptosis of right eye was noted, and there was no redness of right eye. Systemic examination, cardiovascular system, respiratory system, and periodontal examination done, and the periodontal examination showed mild palpable liver 1 centimeter below postal margin. Prostate was dull, but there was no palpable spleen as such. And coming to CNS examination, higher mental functions were with normal, speech normal, cranial nerve examination. On second cranial nerve, bilateral pupils were reactive with relative apparent papillary defect was found in the right eye, and the fundoscopy revealed a papilledema, and concentration reflex were normal. Other cranial nerve and light perception was absent in the right eye, and was present, and finger counting was also present in the left eye.
Pupils are bilaterally reactive RFPD.
Sir, actually, when showing to light, there was initial reaction was that. That's what I meant, sir. But
so the light reflex was present normally.
Not normal, sir. Not normal, sir. Sorry. Then, sorry. Sorry. At that time, meant this there was RIPD present, but the initial.
The RIPD was not like that.
Sorry. It was missed. And other motor system, sensory system, and all within normal limit. And cerebellar, there were no cerebellar signs. There's no meningism, and there was no spinal tenderness. So MRI brain was done. So we showed a right posterior retinal detachment. And the ophthalmic evaluation, ophthalmologist was called, and ophthalmic evaluation was done, which showed a pan uveitis of both eye with retinal detachment and active retinal vasculitis in the right eye. So, ocular manifestations of sarcoidosis. Patient actually ocular disease in initial ocular disease in sarcoidosis can be initial manifestations also, but it can be seen after having a systemic involvement. Ocular involvement manifests about 25 to 60% in the patients with systemic sarcoidosis, and the most common ocular manifestation is the uveitis, and it is about 30 to 70%, and conjunctival nodules, which is about 40%. And acute signs of uveitis like pain, photophobia, lacrimation, or redness might be absent in sarcoidosis. That's what happened in our patient. Actually, he doesn't have any signs of uveitis as such, and so after some time so the patient might have having an active disease, but since the acute loss of vision and signs of uveitis were absent, we will not be able to pick up in the initial stage. So by the time he present to us, it will be very late and there will be intraocular process or diagnosis and treatment. The initiation also will be delayed. So the uveitis is actually anterior, intermediate, and posterior type were there, and classical sarcoid, which is seen in anterior uveitis, is acute iridocyclitis. So fundoscopic findings in posterior segments, usually posterior segment involvement usually show a periphlebitis, that is inflammation around the vessels, and frequent complications in the posterior segment involved in sarcoidosis include cystoid macular edema, cataract, glaucoma, retinal ischemia, and neovascularization. So our patient had a disc edema at that time, initially 2 months back itself. But if you could have picked that up at that time itself, we could have done a better management. But since the patient got delayed treatment and the patient lost to follow-up, we couldn't pick up at that time. And currently now the patient has developed a retinal detachment and developed a vision loss also. So coming to management, corticosteroids are the main management for the ocular sarcoidosis, and cycloplegic use is indicated to prevent for the stagnicity. So learning point. So actually, we started initially on previous admissions, sir. We started him on ATT with steroids. And after starting on ATT, there was no increased weight gain, and he was getting a high dose of steroids also. After tapering the steroids, his symptoms again started to recur. Like he again started to have weakness, and creatose also started to come up. And after coming here, he developed a new ocular manifestations also. And ACE level wise, he had a hypercalcemia during this time, and ACE level wise, this ACE level was
lung involvement.
No lung involvement, sir.
Necrotizing
granuloma in the liver, in the kidney biopsy. Only because of the clinical evaluation, sir. After stopping steroids, he again developed.
Did any of the biopsies come positive for gene expert,
No.
or any of them grow gene?
No.
So the crux is that this young man who presented with fever and weight loss had granulomatous inflammation involved multiple organs, the liver, the portal and the kidneys. And all his cultures, microbiology evaluation was completely normal without a tuberculosis or other and there was no response to empiric antibiotics. He received a full course. And necrosis is described in a minority of patients with arthritis. And arthritis is one is most common, but it's not that weak. This time also his response to serotype was
Very good.
except his vision.
Vision actually is improving. So now my light perception has started after.
Any other questions or comments? John, you did mention the differentials for an acute onset painless vision loss, but you did not put it into the perspective of his past history and give us the etiological differential diagnosis before you went ahead. And the fact that you're thinking about sarcoidosis came out of the blue and it did not feel like it is in flow with your rest of the presentation. But thank you very much for that interesting case. We'll go on to the last presentation for today. Dr. Rohit will be presenting on behalf of Medicine 1. Presentation is titled Timing is Pivotal.